From the beginning of human history, we've been in a fight for our lives. The odds seem insurmountable.
Disease,
epidemics,
the danger of introduction of diseases from abroad.
The enemy outnumbers us 1 trillion to 1, and the battlefield is the human body. But we've fought back. Our champions are many: visionaries, detectives, turners of the tide.
The work of scientists alone cannot eliminate.
But as we've advanced, so too has the enemy. The pathogens have gotten stronger, bolder, deadlier. And that's why BioFire was born. We've created a new way to identify the enemy. We call it syndromic testing. It's faster, more accurate, more precise. With one test, we can identify a patient's infection in about an hour or less. No more losing time with one negative test after another, until hours, days, and weeks have passed without optimal treatment. BioFire's syndromic approach is a symptom-driven, broad grouping of probable pathogens into one test that maximizes the chance of getting the right answer in a clinically relevant time frame, which means we can stem the rise of antibiotic-resistant superbugs. And these aren't things we hope to do. They're things we're already doing. Our respiratory panel is increasing survival rates in critically ill patients. Our pneumonia panel may help patients get better with fewer antibiotics. Our ME panel is reducing time to diagnosis. Our GI panel is reducing length of stay. Our BCID panel is cutting down the time patients spend on antibiotics. Costs are being reduced. Care is getting better. Lives are being saved. At BioFire, we're turning questions into answers, so more doctors and patients can turn battles into victories. The torch has been passed.
Good day! Biomerieux proudly presents today the game changer of infectious disease detection, the BioFire technology. BioFire is known for its syndromic approach. It is a symptom-driven diagnostic method that combines a broad grouping of probable pathogenic causes into a single rapid test. Why is syndromic testing important? Syndromic testing is an informed therapy. It increases the probability of identifying a pathogen using the right test the first time, reduces guesswork and cost of additional testing, informs antibiotic stewardship, and aids in proper care management including admission, isolation, cohorting, and treatment therapy. Without syndromic testing, it is an educated guess. The infectious cause may remain unknown, the right test may not be ordered, the wrong test or no test may be ordered, cost associated with additional testing, patient care may be compromised, and risk of adverse outcomes and patient dissatisfaction. To compare BioFire syndromic testing with the conventional methods, traditional testing uses one sample with multiple tests ordered, which will take hours to days, with individual results in separate reports, resulting to longer patient stay. But with BioFire syndromic testing, it's one sample, one comprehensive test, in about 1 hour for the results in just one report, thus improving patient management. The latest version of this technology is the BioFire Torch, which can run as much as 44 to 264 samples per day, depending on the number of modules fit for the laboratory needs. The film array instrument integrates sample preparation, amplification, and detection. With conventional PCR systems, it takes 30 to 90 minutes hands-on time, with 2 to 6 hours of testing. While with BioFire, it is fast and easy, with just 2 minutes hands-on time and about an hour for the runtime. It is comprehensive. By using Multiplex PCR, it can simultaneously test for multiple pathogens. And lastly, a high accuracy rate of 95% overall sensitivity and 99% specificity. Pouch preparation will only take 2 minutes of hands-on time in the lab. It starts with pouch is inserted into the loading block. Then hydration solution is injected into the pouch through the blue inlet port. Sample buffer is added to the sample injection vial. and the sample is added to the sample injection vial using the transfer pipette. The lid of the sample injection vial is closed and the vial is inverted 3 times to mix the sample. The sample buffer mixture is injected into the pouch in the red inlet port, and the film array instrument is now ready to set up. It is fast and easy, and now the pouch is loaded into the film array instrument. So what happens during the run? Sample moves into lysis chamber where bead beating occurs. Ceramic beads break up cells and viruses and release the nucleic acids. Nucleic acids move from the lysis chamber to the first purification chamber. Then nucleic acid is captured by absorption to magnetic beads, and series of wash steps remove protein, cellular debris, and other potential PCR inhibitors. Elution buffer allows the nucleic acids to be released from the beads and other waste products are pushed back to the previous blisters. Next, nucleic acids move to the first stage PCR chamber, and reverse transcriptase converts target RNA to DNA, followed by a high-order multiplex PCR. Then products from the first stage PCR are diluted to remove any remaining PCR primers, combined with fresh master mix and prepared to be aliquoted in each well of the array. Each well is pre-spotted with a single pair of second stage PCR primers, resulting in specific amplification of target DNA only. A fluorescent double-stranded DNA binding dye monitors each reaction. The film array performs a melt to confirm the presence or absence of assay-specific temperature signatures of the second stage PCR product for each well in the array. In order for an organism to be identified as positive, 2 out of 3 wells must be positive with a melt peak. Melting peaks must fall within their assay-specific temperature range, and melting peaks must be significantly similar to each other. Both internal controls must pass, and these are the RNA and DNA process and PCR too. BioFire has easy-to-interpret results with multiple pathogen detection in just one comprehensive report. This technology also offers the widest menu with 5 panels: the RP2.1 Plus panel, including SARS-CoV-2, BCID2 panel, GI panel, the ME panel, and the Pneumonia panel Plus. The BioFire Respiratory 2.1 Plus panel includes 23 targets in just 45 minutes. The Pneumonia Panel Plus covers 34 targets, which includes bacteria, atypical bacteria, viruses, and antimicrobial resistance genes. And soon to launch, the Blood Culture Identification Panel 2, which covers now 43 targets in just 1 hour. The gastrointestinal panel has the overall sensitivity of 98.5% and 99.2% specificity that can detect various bacteria, viruses, and parasites. Lastly, the ME panel with 14 targets requiring 200 microliter of CSF, the fastest multiple pathogen identification testing of bacteria, viruses, and fungi associated with community-acquired meningitis and encephalitis. Now, BioFire Film Array is installed in 17 sites all over the Philippines, 10 in Luzon, 6 in Visayas, and 1 in Mindanao. A pleasant day to all. I am delighted to introduce our speaker this afternoon to talk on this interesting topic on BioFire entitled F.A.S.T, or BioFire Assays for Swift and Targeted Treatment, a rapid multiplex PCR test for infectious diseases. Our speaker is an infectious disease specialist, an associate active consultant in Makati Medical Center, also an active consultant in Asian Hospital and Medical Center. Lastly, she is an international full active member of the Association for Professionals in Infection Control and Epidemiology. Please help me welcome Dr. Marion Kwek.
Good afternoon. Thank you for the opportunity to discuss one of the latest innovations in infectious disease diagnostics. It's F.A.S.T, BioFire Assays for Swift and Targeted Treatment, Rapid Multiplex PCR Test for Infectious Diseases. For this session, I will talk about the challenges in traditional ID diagnosis and how BioFire Rapid Multiplex PCR tests can address these challenges. I will discuss briefly about syndromic testing, with emphasis on diagnosis of respiratory illness and the role of multiplex PCR tests in the setting of the COVID-19 pandemic. Last, I will also talk about the use of multiplex PCR in antimicrobial stewardship. There are three questions we want answered by the clinical microbiology laboratory. The first question is the patient infected? If yes, then the next question would be, what is the etiologic agent of this infection? Is it a bacteria, a virus, a fungi, or parasite? Lastly, we want to know what to treat this infection with. Let's review the conventional methods in microbiologic diagnostics. The first is microscopic examination of the clinical specimen. Some examples would include stool microscopy for parasite and ova, and special stains like gram stain or acid fast stain, or blood smears for parasitemia. And while it answers the first two clinical questions, it doesn't answer the third. The second is the isolation of the organism through culture and its identification based on biochemical reactions. The isolated bacteria is then tested for its susceptibility to antimicrobials, which answers the third clinical question. The third conventional method in diagnosis is the serologic or immunologic test, which can be used for early diagnosis, and it is useful in organisms that cannot be cultivated in the lab. It's also useful to measure antibody titers. There are, however, limitations to these conventional methods. Conventional culture is lengthy, time-consuming, and tedious, and we are at the mercy of the growth of the microorganism. Conventional pathogen identification have a long turnaround time, anywhere from 72 hours to as long as 7 days. And in some laboratories who do not have the microbiology facilities, the turnaround time can even be longer as the labs have to be sent out of the facility. There are numerous data to support the benefit of timely and early appropriate antimicrobial therapy on mortality. And this makes this limitation have a very big clinical impact. Another limitation of conventional methods is that it is largely skill dependent on the microbiologist or the medical technologist. And in our country, we do have the problem of lack of trained personnel, mainly from brain drain, with skilled staff migrating overseas. Another limitation of conventional methods is that culturing of certain organisms might not be possible. Other limitations include the added biologic risk when doing bacterial or viral cultures. Some hospitals do not have the in-house microbiology laboratory or may not have the space for the big equipment needed for a standard microbiology lab. And while guidelines recommend getting samples for culture prior to starting antibiotics, in actual clinical practice, the urgency of starting therapy often precedes the submission of samples, and we know that cultures may be negative due to a prior antibiotic therapy. To overcome these unmet needs in diagnosis of infections, current trends in diagnostics are shifting towards rapid diagnostic tests or RDTs, which aim to have rapid results such as same-day lab-identified specimen, tests that may be done at point of care, and tests that use a single platform to detect different organisms without the need for multiple equipment or needing only a single sample versus a mixed bag approach. So when we say a mixed bag, it means that there are different tests that have to be done to diagnose for different organisms. So why do we use RDTs in ID diagnosis? This aims to improve diagnostic capabilities by expediting the identification of organisms, and this would lead to timely identification and susceptibility data, which eventually leads to appropriate antibiotic therapy, and it will also assist antimicrobial stewardship programs, wherein this would allow for early streamlining or de-escalation of antibiotics or escalation of antibiotics when needed. The information from RDTs will also provide the information needed for a faster initiation or removal of certain isolation precautions. So the BioFire film array system is a multiplex PCR system that integrates sample preparation, amplification, detection, and analysis. And it often requires a few minutes of hands-on time and requires minimal training. It also forgoes the need for precise pipetting, which is found in your conventional molecular diagnostics. The patient sample is loaded into a pouch, which is placed in the system for an automated test. The turnaround time to result is approximately an hour, and it is comprehensive because it can test for several pathogens using a single sample. So when we say multiplex PCR, we use a fluorescently labeled probe with more than one set of primers, and this technology can be used for simultaneous detection of multiple organisms as well as antibiotic resistance markers. Now I will be introducing the concept of syndromic testing. First, let's define what a syndrome is. A syndrome is a set of symptoms and signs that are correlated with each other and often with a specific disease. In syndromic testing, you have a panel that targets a comprehensive grouping of pathogens that could be causing a specific syndrome. So some key syndromes would include your respiratory infections, gastrointestinal infections, your meningitis or encephalitis infections, and sepsis. The BioFire Film Array Multiplex Real-Time PCR has several syndromic tests available in their system. So they have two panels for respiratory infections, namely the Pneumonia Plus panel for lower respiratory tract infections, the Respiratory 2.1 Plus panel for upper respiratory tract infections, the ME panel or meningitis encephalitis panel, gastrointestinal panel, and the blood culture ID panel. For today's discussion, we will be focusing more on the pneumonia and respiratory panels. I will be presenting one case. So this is an 82-year-old male with nasopharyngeal CA who recently had chemotherapy and was recently given levofloxacin by his attending oncologist. He had a recent hospitalization 2 weeks prior and was treated for pneumonia caused by Pseudomonas aeruginosa. He came in for fever and shortness of breath, and on physical examination had multiple oral ulcers and white plaques on the tongue. He was neutropenic on admission with ANC of 697. The initial X-ray showed fine opacities diffusely on both lungs which was attributed to pneumonia. And because he was managed as a case of febrile neutropenia, he was started on cefepime, considering also the prior isolate of Pseudomonas aeruginosa from the past hospitalization. The levofloxacin given outpatient was continued. And for the oral ulcers and the oral thrush, he was started also on acyclovir and fluconazole. The patient was started on GCSF, and because of the time that the patient was admitted, wherein we are already in the COVID pandemic, an NPS and OPS swab was taken from the ER, which was negative for SARS-CoV-2. Cultures were also taken upon admission, and these samples included blood, urine, and sputum samples. On the same day, there was progression of respiratory distress, prompting the eventual intubation of the patient. Upon intubation, an endotracheal aspirate was sent for SARS-CoV-2 PCR and the Pneumonia Plus panel. An endotracheal aspirate culture was also requested, but the sample collected was deemed insufficient by the laboratory and was not processed. So the Pneumonia Plus panel tests for 34 targets, which includes 27 bacteria and viruses causing pneumonia, as well as 7 genetic markers of antibiotic resistance. And these are the targets that are tested in this panel. So the results came in on the same day. For the endotracheal sample, it was positive for SARS-CoV-2 PCR, and the patient was started on remdesivir as well as supportive treatment for COVID. The sputum cultures which were taken on admission eventually yielded normal flora. As mentioned earlier, the endotracheal aspirate sample for culture was not processed due to the inadequacy of the specimen. However, the Pneumonia Plus panel demonstrated the presence of Staph aureus, which was not MRSA, as based on the absence of the resistance genes conferring methicillin resistance. Levofloxacin was discontinued, and there was no further addition of MRSA coverage for this patient. He was eventually extubated after 5 days, and the X-ray showed further clearing of the infiltrates, which was present initially. So this case would highlight that bacterial co-infections can occur in COVID-19, and multiplex PCR provides the benefit of etiologic diagnosis of co-infections. So what is the data on co-infections at the time of COVID-19 presentation? So in one meta-analysis which looked at literature from 2019 to April 2020, they found that bacterial co-infection is present in 3.5% of patients who were hospitalized for COVID-19, and this would include all severity. But the rates of bacterial co-infections were higher among those who were admitted for severe COVID-19. In this particular meta-analysis, they looked at the diagnostics that were used to detect the presence of bacterial co-infection. And it is worthwhile to note that for this study, the diagnostic methods used to detect bacterial co-infection mainly use conventional diagnostics, such as respiratory or blood cultures, and only 2 studies demonstrated the use of respiratory nucleic acid amplification tests. And this might be a reason why the presence of bacterial detection might be low in this population. Another meta-analysis done reviewing literature from 2019 to April 2020 looked at bacterial co-infection among patients admitted with COVID-19. And in patients from varying severities, there was 7% bacterial co-infection and 14% bacterial co-infection among those who are admitted in the ICU. It's also worthwhile to note that 3% of their cases also had co-infection with other viruses. Looking at the BioFire pneumonia panel as a tool in diagnostics, so in one study in France, they looked at COVID-19 patients admitted in the ICU, and they found that 13 out of the 47 cases with COVID also had bacterial pneumonia co-infection at the time of presentation. In another study in Belgium, for a similar population, they found that 13 out of 32, or that's around 41% of ICU COVID-19 patients had bacterial pneumonia co-infection at presentation. And the data provided by their pneumonia panel actually led to accelerated antibiotic modification in 15 out of the 32 patients. This is a 40-year-old male with critical COVID-19 pneumonia who transferred from another institution on day 12 of his hospitalization. He had an extensive antimicrobial history and received ceftriaxone, azithromycin, remdesivir, piperacillin tazobactam, and vancomycin at the other institution. And on admission, the patient was already on meropenem and linezolid, which was continued for this confinement. He was febrile during this time, and additional antifungal coverage was also started, so he was given micofungin. He received the supportive management that are given for COVID-19 patients, such as steroids, hemoperfusion, tocilizumab, and convalescent plasma therapy, and still had persistent febrile episodes at the ICU. This was the X-ray done from admission, showing bilateral infiltrates, but on the 7th day of hospitalization in the ICU, showed further progression of the lung infiltrates. Our impression at this time was a possible ventilator-associated pneumonia. During the time that this patient was admitted in our ICU, we have been seeing increasing cases of carbapenem-resistant Acinetobacter baumannii pneumonia. So with our impression of ventilator-associated pneumonia with risk for carbaresistant A. baumannii, polymyxin B was empirically started. An endotracheal aspirate sample was requested for culture and pneumonia plus panel. However, we were able to send the sample on the 2nd day only of polymyxin B. Cultures were eventually normal, flora, but the pneumonia panel was able to demonstrate the presence of Acinetobacter baumannii with the presence of the New Delhi metallobeta-lactamase gene. And this would mean that this isolate would probably be resistant to carbapenem. This was the X-ray of the patient on the 5th day of polymyxin. And this showed some decrease in the infiltrates compared to the previous one. So what is our takeaway from this case? Multiplex PCR not only identifies the causative agent, but also provides early information on drug resistance, which would then help us have targeted therapy. Multiplex PCR can address limitations of conventional cultures, such as the turnaround times, the amount of sample required, and the detection of organism despite being on an antimicrobial. So the data on secondary bacterial pneumonia and hospital-acquired infections in COVID-19 in general is very limited. In a meta-analysis, there was secondary bacterial pneumonia in 14.3% of hospitalized COVID-19 patients. And in a study in China, 13.9% of COVID-19 patients in the ICU developed secondary bacterial
100.
pneumonia. In another study, secondary bacterial pneumonia rates in hospitalized COVID varied with severity, with the lowest for moderate COVID-19 infections to as high as 34% in critical COVID infection, despite the widespread use of antibiotics.
Alin yung ano, may maingay na.
There are challenges in the current pandemic settings, and this would include resource allocations, not just of medications, but also our isolation rooms and beds. Infection control in a pandemic settings can be compromised. Diagnostic capability can be overwhelmed. And the turnaround time, if you have a lot of samples to process, can also be affected. So in this third case, I would like to present, we have a 50-year-old male with hypertension and asthma who came in for chest pain and shortness of breath. On review of symptoms, he had occasional cough a few days prior, which he initially attributed to asthma exacerbation. He had incomplete childhood immunizations, and upon review of possible exposure history, he mentioned that their house help had respiratory symptoms a week prior. On admission, his x-ray was normal, but cardiac enzymes were elevated, and he was diagnosed with acute ST elevation MI and was a candidate for PCI. An RP2 panel was done on admission. So the respiratory 2.1 plus panel targets the following viruses and bacteria for identification. So the patient's result came out shortly. The SARS-CoV-2 was not detected. However, there was detection of Bordetella pertussis. And the interventions that followed because of these findings included the changes in the room placement. Initially, this patient was supposed to be admitted in the isolation room, but was stepped down to the regular ICU. The isolation precautions were shifted from full barrier precautions to standard and droplet. He was started on antimicrobial therapy with azithromycin, and his household contacts were also managed accordingly. So this case highlights that multiplex PCR allows for early turnaround time and initiation of appropriate infection control measures. So we have shown that multiplex PCR has an easy workflow, it has a rapid turnaround time, and has a broad coverage of pathogens that can be detected in one test. However, the additional information can lead to problems in interpretation, and the multiplex PCR cannot differentiate live versus dead organisms. There's also the issue of cost of the test, and this is something that is very important when we have majority of our patients shouldering the cost of their hospitalization. However, we have to look at cost not just at face value, but also its cost effectivity. And there are benefits to the use of the BioFire Film Array Pneumonia Panel in antimicrobial stewardship. In this study, where they aim to compare results of routine cultures versus those obtained from a pneumonia panel, they saw that the pneumonia panel identified at least one bacterial target in 63% more than standard of care culture and identified nearly twice as many total bacterial targets as cultures. However, incidentally, when they were doing the study, they found out that there was potential for antibiotic adjustment in 70% of patients based on the pneumonia panel result, including the discontinuation or de-escalation of antibiotics in 48% of patients, with an average savings of 6.2 antibiotic days per patient. In the same study, they found that for the different antibiotics, vancomycin and piperacillin tazobactam comprises more than 50% of those that can be de-escalated or discontinued using the information from the pneumonia panel. Another study looked at the utility of your FilmArray RP panel and the antimicrobial stewardship program. And this study was to determine if timely etiologic diagnosis could have an impact on medical management in relation to antibiotic and antiviral prescriptions. So they found that there was a significant decrease in antimicrobial prescriptions with the BioFire RP panel versus conventional immunofluorescence assay methods done in their center. And for pediatric patients, they decreased their antimicrobial prescriptions by 23%, and for adults, they decreased it by 13.6%. The median time from sample collection to results reported to the attending physician was around 1 hour and 52 minutes versus 26 hours 40 minutes for their conventional methods. And this led to earlier intervention. So does this mean that we should say goodbye to our cultures? So not necessarily. Your multiplex PCR is a good test, but it's not perfect. It lacks universal organism coverage and can only test for the targets that are part of the panel. It also lacks resistance determinants. It can have false positives due to cross-reactivity or false negatives due to preferential amplification of one target over another. Cost is also a limitation of this test, but again, we can justify the cost with its cost effectiveness when used in conjunction with antimicrobial stewardship programs. And multiplex PCRs have not replaced conventional microbiology. So I'd like to introduce the concept of diagnostic stewardship. And it's important that we know which test to order at what time for which patient. And the diagnostic stewardship should be used hand in hand with antimicrobial stewardship to lead to better outcomes for our patients. So I'd like to leave you with a summary. Turnaround time to etiologic diagnosis is a limitation of conventional ID diagnostics. The BioFire Rapid Multiplex PCR test can provide the unmet needs of clinicians in diagnostics. Syndromic testing is screening for a comprehensive grouping of pathogens that could be causing a specific syndrome. BioFire Pneumonia Plus panel and RP2 panels may be used in patients presenting with respiratory symptoms. Multiplex PCR can help in the escalation or streamlining of antimicrobial therapy. So I'd like to leave you with this slide. Ordering a diagnostic test is like picking your nose in public. If you find something, you have to know what to do with it. Thank you for your kind attention.
Thank you so much, Dr. Kwek, for a very interesting lecture on syndromic testing and the BioFire technology. Now we move on to the Q&A portion. I'd like to request all the participants to please enter your questions in the Q&A chat box, please. Thank you. For now, I'd like to start with this question, Dr. Is there a laboratory test algorithm for respiratory infections that you can share with us, injecting the application of the multiplex PCR? Thank you.
Well, in our center, it's not really part of our pathway yet because it's something that's relatively new. But we have encouraged our clinicians to use this for patients presenting with respiratory symptoms. And we have more experience with the pneumonia panel because this was the one that was first made available to our center. And part of the, not really a formal algorithm, but it's something that we have been using. So anyone coming in presenting with a respiratory illness syndrome would usually be requested, a panel would be requested by the clinician.
Another one, Dr. Kwek. What is the minimum copies per ml of bacteria that can be detected by the panel?
What is usually considered significant is, correct me if I'm wrong, but the one that is used to say that it's significant is around 10 to the 5 copies of the organism. But in some reports, they just state whether it's detected.
Thank you, Dr. Kwek. Another is, what is your experience in diagnosing COVID-19 with the use of a BioFire RP 2.1?
Okay, so we have had some cases. Now, as I said, it's something that's fairly new and we've only recently started to use it. But we've had a few who were identified using the RP2 panel. And this is actually one of the reasons why patients would ask, why is the cost of the stat PCR faster? The stat would be more expensive. It's actually because this is the one that we have been using in our facility when we request for a stat PCR test. So this is a rapid test as mentioned earlier. And usually patients would stay in the ER. If you would use the conventional, they would probably be staying there until the following day. So we do have experience wherein they're in the ER only for an hour. And then once their cells are in, we are able to expedite their placement inside the facility.
Thank you, Doctor. Another is BioFire only useful during this pandemic?
No, actually, we have been using the BioFire even before this pandemic started. No, this is just an added test. No, they added the SARS-CoV-2 as part of the RP panel, but we have been using this even before. I've had other cases which I did not present here, but I have used each of these panels in my clinical practice, and they were able to identify tests that organisms that were not identified using conventional methods, which actually affected the clinical management and adjudication of the patient.
Thank you, Doctor. Another question from Dr. Atienza. In your experience, is this covered by PhilHealth?
I cannot answer that if it's part of the PhilHealth, because usually PhilHealth would give you a standard case rate per disease. But I'm not, in terms of the specific, I'm not sure if it's the same application as for the non-formulary medications. So I don't know if diagnostics will fall under this limitation by PhilHealth. But yeah, I cannot answer that.
Noted on that, Doctor. Another question, does a positive COVID-19 result in BioFire still need to be retested or validated using a traditional RT-PCR test?
Well, actually, it's already a PCR test. If you are clinically considering COVID and you have a PCR test via the multiplex PCR, which says that it's positive, then you can actually use that to say that this patient is already confirmed as having COVID-19. In fact, even in the latest guidelines, even an antigen test by itself can also be used to say that someone has COVID when they are symptomatic and have the clinical parameters for COVID-19.
Thank you, Doctor. Next, Dr. is what are the limitations of BioFire?
For me, I think the main limitation that I encounter is really the cost of the test. We know that patients mainly shoulder their own hospitalization, but this is where cost effectiveness comes in, because sometimes when our treatment is delayed because we are waiting for the results, that time that we save can actually in the end be a saving for our patient rather than a cost upfront.
Thank you, Doctor. Another question, do you still request bacterial culture together with BioFire?
Yes, we do that. So I mentioned earlier that we can't do away really with our conventional cultures. And also we have to consider that it is possible that our patients can be infected by an organism that does not belong to the targets that are being detected by the test. So the organisms that are included per panel would have your usual suspects. But then we know that we do have patients who don't have the usual suspects infecting them. And that's where your culture can also come into play. For example, in the pneumonia panel, I think we don't have Burkholderia as part of it. So it's something that we sometimes see in clinical practice. And you won't see it in your panel, but you will see it on your culture.
Next question, Doctor. Can BioFire still detect the pathogens even if the patient have taken antibiotic treatment prior to sample collection?
Yes, it can. Actually, that's the reason I presented the second case. He had prior sputum samples, and even the first case had sputum cultures. We did not which did not show any pathogen, and then it was in the panel that showed that there was. And this is one utility because PCR can detect molecular components or genetic material of the pathogen even if it's dead. And this is actually one caveat when using the BioFire film array test, because some patients who may have had a recent infection that has already resolved could also test positive for an illness by using this panel.
Next question. Is there any parallel study between BioFire and other methods, including the gold standard?
Yes, there have been several studies comparing your standard culture and your BioFire film array panels, and also head-to-head comparisons between the use of the individual PCR studies that are being done in other countries and the Multiplex PCR. And they have good concordance in terms of its ability for the other molecular tests to detect the pathogen. But they have shown that in other cases, really, the panel can even be superior in detection of other organisms compared to your conventional cultures.
Next, doctor, is BioFire been FDA cleared or approved?
Yes, it's an FDA approved test. Locally also, Philippine FDA also approved it.
Thank you, doctor. Last question, I think. If we don't have any other questions in the chat box, last is, what do you think BioFire should have or develop in the future?
I think there are other syndromes that are not yet part of the available panels. So I mentioned that that part of the syndrome would include your bone and joint. So that's something that I think you're working on it already, if I'm not mistaken. So bone and joint infections can have a panel. STIs can also be another test that can probably be improved on by the technology. And what's good about this is you have a machine. You don't have to buy several machines. You just have one machine that you use, and it's just the cartridge that differs when you run your test.
So I think that's all for the Q&A session, doctor. We'd like to end that part. And then again, I'd like to thank you, Dr. Kwek, for a very interesting and very informative lecture, as well as addressing the questions of our participants. So to all the participants also, we'd like to thank you all for attending today's session on BioFire, and may we invite you all to visit our virtual booth for a chance to win the BioFire toy bags. So again, thank you so much and keep safe.
Okay, so on behalf of the Board of PSMID, I would like to extend our gratitude to our speaker, Dr. Marion Kwek, for enlightening us on this new diagnostic technology and providing guidance on how we can properly utilize BioFire film array multiplex tests in our practice. We are likewise grateful to our moderator, Janice Balbuena, and also to Biomerieux for hosting this important session and for consistently supporting the activities of PSMID. May I present the certificate of appreciation to Dr. Kwek? Can you please post it? So, okay, Marion, your certificate will be sent to you. Thank
Yes.
you very much. Okay, bye-bye.
Thank you, Dr.